So pretty much what I'm discussing here is a mid-back placement in relation to the low back and the neck. Oftentimes people quite realize that their torso weighs a significant amount and it's placed right on top of their low back. So if you're experiencing chronic low back pain, then it can be driven by your torso either going in one direction or another abnormally. So what I'm going to show you here is placement of what we call the thoracic spine, which is the mid-back. You'll notice that this is the side view. So what we're doing here is that we're looking at the patient like this. You're looking at the patient's left side. And so you want to be as close to the green as possible. Obviously, green is normal. And you want to be, as close to the green as possible. So that being said, so what we're having here is technically is a further back placement of the mid back on where it should be. So if it should be here, it's in this position. What does that do? Number one, it forces the neck to go forward, and your low back is more than likely more forward in this case too. So we have right here what we call posterior translation, back placement of the thoracic spine. And so what would that lead to? It'll lead to back pain, it'll lead to shoulder blade pain, ongoing stiffness, whether it be on your day-to-day, working in front of a computer all day, working out. You'll probably feel some discomfort with gym activities, putting a bar on your back and stuff like that. So what we did is that we put the patient on what we call an EAT protocol, exercise adjustment traction. Exercise only because we want to warm up the spine to be able to get ready for an adjustment and for what we call traction. That's the molding that happens throughout the course of time. So that being said, after it takes months, it's not something that can just really happen from one week to another. So I'm always very transparent when it comes to this, like braces, right? It's like you can't push the tooth back into perfect alignment within a week or a month span. It's just impossible. So your spine works that same way. So throughout repetitive and recurring trauma all the time, and let's just say for a worth of 3 decades, and then hey doc, heal me. No, it doesn't work that way. So it takes time to be able to mold, but it can mold, especially if it's not having any arthritis, and I'll explain what that means. So you'll notice here that we have the squares, and there's a space in between every square. That's what we call the disc. It accounts for about 25% of your height, approximately. A lot of professionals say that it's for shock absorption, but also for movement, for being able to have the versatility to be able to move in every direction. And so long story short, what you want is to be able to have that space. Once you start rubbing bone on bone, that means that the disc has obviously decreased, and that's what we call degenerative disc disease. What happens when that happens? So right behind, right here, we got a whole set of nerves that exit from every single segment right here. The spinal cord is in here. It's a continuation of the brain, will shoot down, become the spinal cord, and then a bunch of small nerves will come out. Now, what you want is to be able to clear that space, and you can see part of it here. You can see that hole. So you can see the hole here, and so that hole needs to be open in order for the nerve to come out and not have any nerve pain, nerve damage. If you injure a nerve, you can potentially take years to be able to heal that nerve if it's even able to be healed. That being said, the point is to be able to push that forward. You'll see that there's a pre and post here, and it's very, very different. So positionally, we're way back here, and this is the after, the follow-up reevaluation x-ray, and you can see just a great deal of improvement. So we're going to go through pretty much how to improve that posture over the course of time. We'll have you on over here. Come on down underneath your arms. Good. And hold this for me. Perfect. Perfect. You okay? All right, perfect. The amazing hair, wow. All right, cool. I'm gonna have to raise your head. All right, so when we're talking about the torso, being further back, causing a lot of stress on the lower back and the neck and leading to that shoulder blade and mid-back pain, what's the most obvious thing to do is to be able to bring it forward, but past that midline. So if we only bring the patient up to neutral, then that'd be the exact same thing as you lying down on your bed. It makes absolutely no difference. You're still the exact same way. So what we have to do is push it past that, way past that, and accentuate the what we call the mirror image. So the mirror image of this is pretty much bringing you forward and stabilizing you in that position. So what are we causing here? This is technically what we call anterior translation of thoracic spine. We're just bringing you forward in relation to the pelvis. Pelvis is stabilized because we don't want that to move if that's doing okay. The neck is in the neutral position and possibly even slightly lower. And the mid-back is significantly brought up, which would put it in a more forward position if the patient were to be standing up. This, over the course of time, will significantly improve posture and get rid of the mid-back pain, the shoulder blade discomfort as well. Oftentimes, when the mid-back is too far back, it will put a lot of stress and wear and tear on the lower back and pelvis and lead you to have that discomfort maybe in the hip flexor, down the glute, in the lower back, maybe some sciatica, some neck pain as well. But this is an amazing way to be able to correct that. You leave the patient here for an extended amount of time, for about 20 minutes, and throughout the course of time, it will change.